And now we're going to talk about some examples of some reasons that people can have strabismus. And of course we need to review the extraocular muscles. So remember that the superior rectus in general, its main action is to pull the eye upward, but we've probably alluded to the fact that the superior rectus also has some other actions that when it contracts it can also pull or turn the eye slightly inward in this direction. The top of the eye would rotate inward. That the inferior rectus would do kind of the opposite. It pulls the eye downward, and when it contracts, it turns the eye slightly outward. It rotates it this way. That's something that's beyond the scope of lecture. You don't need to know. The medial rectus, this is the left eye that we're looking at. So if this is the left eye looking at us, the medial rectus contracts, it turns the eye inward to the nose. The lateral rectus, if it contracts and pulls the eye outward. And then the superior and inferior obliques, which as you can see from the diagram, the way that they are oriented, when they contract, at least when the eye is looking straight ahead, they tend to mainly affect the torsion, the twisting of the eye. The superior oblique, if it contracts, would turn the eye like this. It would turn the top part of the eye inwards, that's called intorsion. And the inferior oblique, if it contracts, would turn the eye this way in a clockwise fashion, in what we're looking at here. And that would turn the top of the eye outward, and that's called extorsion. We also mentioned that if, in the case of the superior oblique, that if the eye itself is, the medial rectus is acting and the eye is adducted, turning in, that at that point when the superior oblique contracts, it causes another thing to happen. Its main action there is that it will cause the eye to move downwards, to depress, whereas the inferior oblique would cause it to look up. The main thing here is just to note that the superior oblique, the way that it acts, really changes depending on which way the eye is looking, and that will become relevant later. So we'll start off now with just the case of a 6 nerve palsy in terms of what we expect. So obviously we expect the patient to have limited abduction. The ability of the eye to turn outward will be somewhat limited. However, we've shown examples where if there's a very slight 6 nerve palsy, the abduction might look full to the examiner. And then what the patient should tell us subjectively is that they have a double vision, that the double vision is horizontal double vision. It gets worse when they look to one side. So if it was in the left eye and it was the lateral rectus palsy, then it would get worse when they look to their left side, because that's where they need their lateral rectus to act in the left eye. That it would improve when they look to the other way. So it would improve when they would look to the other way, because when the patient would be looking to their right, they need their medial rectus to act, not their lateral rectus. So looking to the right is not a position that, or gaze that would involve the lateral rectus, and they'll be able to do that just fine. And their diplopia would also be a lot less better or even absent when they look up near at something, because again, when we look at something up close, our eyes need to converge. We don't want our lateral rectus to be acting because that pulls our eyes outward. We want it to favor our medial rectus. So someone who has a 6 nerve palsy often is able to read it near without any problem. And if we do our alternate cover test, we would see this same sort of pattern, that we would see an esotropia that got worse when a patient looked to their left, and if it was happening in the left eye, that became much less when they looked to their right, and much less when they looked at something up close. So this is an example of someone with a 6 nerve palsy. This person, when they're looking straight ahead, we don't see any issues. They might be having some double vision, but we certainly wouldn't see it. When the patient looks to their right, we can see that they probably are experiencing a lot of diplopia here. We can see that the left eye is able to turn completely inward, their right eye is not turning inward. We don't know, obviously, where the patient's being asked to look in this case, but we'll assume that the patient's now being asked to look to their right. And when they're asked to look to their left, both eyes are able to look to the left, no problem. So this is a case of a right 6 nerve palsy. So what about a 3rd nerve palsy? So in the case of a 3rd nerve palsy, basically all the muscles are being affected except 2, the lateral rectus and the superior oblique. So let's pretend that none of the muscles are acting except for the lateral rectus and the superior oblique. What would we expect to happen to the eye? Well, because in terms of horizontal position, because the medial rectus is not acting, only the lateral rectus is acting, the eye is going to be pulled outward. What about the vertical position? So in terms of the vertical position, the main two that we might think of, the superior and inferior rectus, they both are not working. So that won't really have any effect on the eye position because it's kind of balanced. And then the obliques, the inferior oblique is not working and the superior oblique is working. The inferior oblique, we said, in terms of a vertical position, pulls the eye upward, so that's not working, whereas the superior oblique is working, and so the net action will be that the eye will go down because of the superior oblique's action and out because of the lateral rectus's action. Of course, we will also have involvement of the lid, as we know. So here's a case about someone who has a third nerve palsy. When they're looking straight ahead, the eyelid's closed. When we open up their eye, the main thing that we see here is that the eye's out. The eye's, because of the lateral rectus action. We don't really see in this particular case that the eye is down and out so much. Of course, again, when the patient's asked to look to their right, they're able to do it not bad because they have their lateral rectus here, but any other way, if they're asked to look to their left where they need their medial rectus, that's a problem. If they're asked to look up where they need their superior rectus, that's a problem. If they're asked to look down where they need their inferior rectus, that's a problem as well. That's a classic case of a third nerve palsy. But again, we've tried to stress that someone, when it's just starting, might come in and with a much more subtle look where there might not be an obvious ptosis and the patient might only be complaining of some diagonal or vertical diplopia. And it's very important to be cautious with those sorts of cases. Again, a presumed diagnosis, if we're worried about third nerve palsy, is that they have an aneurysm in the posterior communicating artery that's causing this third nerve palsy until proven otherwise. The last thing that we see here that, of course, is expected in the third nerve palsy is the dilated pupil and the dry pupil. This is because the third nerve carries the parasympathetic innervation to the eye, and parasympathetic innervation causes the eyes to constrict. And so if the parasympathetic system is not working, then you're left with net sympathetic tone and the pupil is dilated. So I'm going to show you an example of a fourth nerve palsy, and this comes from the following website here, which has a wonderful collection of videos, of eye movement videos, if you're interested in seeing some examples. And this specific example is taken from the University of Utah. So let's see here an example of a fourth nerve palsy. So we have a situation where there's three components to this test. When the patient's looking straight ahead and the alternate cover test is being done, we see that the right eye comes down and the left eye, as it's uncovered, goes up. And that seems to suggest that the resting position of the eye where it wants to be is that the right eye wants to go up when it's not being forced to, and the left eye wants to go down. And that goes along with the fact that there's a right fourth nerve palsy. When the patient is asked to look to their rights, we don't really see much of a strabismus here. We don't see so much vertical movement, and that's because in this particular circumstance, the fourth nerve in the right eye is not so involved. But when the patient has to look the opposite way to their left, the fourth nerve and the trochlea is very responsible for vertical action here, the superior oblique, and we're going to see a very obvious strabismus that comes out. The right eye comes down, the left eye goes up. Some people sometimes ask, why is the left eye going up? Is there something wrong there? And I'll just remind you that if you move one eye, you have to move the other. So if you have a fourth nerve palsy in the right eye that causes the eye to go up, then the left eye has to ascend as well. So that you never see just movement of one eye alone. When the patient tilts their head to the right over here, we see much more impressive movement, and that's because when you're tilting your head to the right, you really need your fourth nerve palsy to be very your fourth nerve, your superior oblique, to be very active. However, when you tilt your head to your left, you don't really need your superior oblique. And so it's not very apparent here. So I would expect just that a medical student should be able to appreciate that a fourth nerve palsy will cause, amongst other effects, an effect on the vertical position of the eye, which can be observed through alternate cover tests, and that one of the things that can tip us off is that the vertical imbalance really changes depending on whether the patient's looking to the right or the left, or whether they're tilting their head to the right or to the left. I think to know the specific details about what's going to happen when they look each way, I think would be less expected from my perspective for a medical student to know. Although, again, if you want to excel at this, then it would just be to know that when you that it gets worse when you tilt your head to the side of the fourth nerve palsy, and it gets worse when you look away from the side of the fourth nerve palsy. And whichever side the fourth nerve palsy is, the eye is going to tend to want to elevate when it's not being used, and that means that when you uncover it, you're going to see it come down. I hope that's clear, and feel free to rewind it and watch that section again. So, myasthenia gravis is a very tricky condition that often can fool us because it can basically do anything to the eyes. It can cause there to be an esotropia, an exotropia. It can cause the eye to be have a hyper or hypotropia, and it can vary. One day it can be a hypertropia, the next day it can be an esotropia. So when we see a variable pattern that's both varying in how the strabismus is, horizontal one day, vertical the next day, and also that's variable in terms of the time, so that people classically with myasthenia will say that early in the day they're doing okay, but as the day proceeds and they're using their eyes much more, things fatigue out and the eye disease becomes manifest, and that's when their diplopia becomes most prominent. So other features that we would look for in addition to the strabismus would be a ptosis, where the eyelids are affected also, and it's a fatiguable ptosis. So the eyelid's not just down. We'll see an example of how it fatigues. We'll see that in a moment. Orbicularis weakness, where the patient tries to close their eyes as tight as they can, and we're actually able to pry open their eyelids without much effort because of the effects of the myasthenia gravis. There's some other signs like a Cogan's lid twitch. This is an unusual sign where we're not going to, I think it's beyond the scope of this lecture here. We've already talked about the ophthalmoparesis, and notice that the pupil should never be involved. So you could have someone come in with the picture that we showed of the third nerve palsy with the eyes looking exactly like that, except what would tell you that that can't be myasthenia is that the pupil is dilated, because myasthenia does not affect the pupil fibers. So here's an example of a fatiguable ptosis. And what we're going to see is that if you look at this woman, she's being asked to look up right now. And right now there's a bit of a ptosis that you might notice. The eyelid's a little lower than it should be, probably in both eyes, more in the left eye. But watch what happens when she continuously tries to look up. As you know, as she continuously tries to look up, she's going to require that her levator muscle in the eyelid here continuously contract in order to keep the eyelid elevated. And because she has myasthenia, it's going to weaken, and the eyelid's going to fall down progressively as she continues to look up. Let's observe that right now.
Keep looking up here. Keep looking. And you guys, I want you to look at her left lid. Keep looking.
See the way the lid's coming down.
Keep looking. Keep looking. Keep looking. You see it coming down? Okay, keep looking.
So this is an example of a fatigable ptosis, and that's something that's very specific for myasthenia. We have a lot of elderly patients that come to us with ptosis, but this sort of situation where the eyelid falls down as they keep looking up is not typical, and that is very suggestive of myasthenia gravis. Another reason that people can have strabismus is thyroid eye disease. And thyroid eye disease usually is very overt because it causes the eyes to have a very unusual appearance, and that's because one of the things that happens in addition to the strabismus is that the surface often becomes red because of the inflammation, and the eyelids often retract because of fibrotic changes that give the eye this glare or a very stare-like, scary appearance that can happen with thyroid. So any adult that comes with a new onset of strabismus, particularly when it doesn't really have a pattern of any cranial nerve palsy, beyond myasthenia gravis, we always need to think about thyroid eye disease as a possible cause. Other manifestations, of course, of thyroid eye disease when it becomes very significant is that you can get a proptosis, the eyes bulge forward, and there's actually this feature that's, again, more advanced and beyond the scope of this lecture called resistance to retropulsion. And the idea there is that with any particular person, if you ask them to close their eyes, you can actually gently push the eyes backward a little bit without resistance. In this case, as you try to push the eyes backward a little bit, very gently of course, you would encounter tremendous resistance. Another thing that in thyroid eye disease we look for is that as a patient looks down, they develop this lid retraction. So look at this patient here. When they're looking straight ahead, you don't see any sclera up here, but when they're asked to look down, all of a sudden the sclera is exposed, and that shouldn't happen. The eyelid should go down as the eye looks down, but here, because it doesn't, because the eyelid is still staying in its position, because of the thyroid eye disease, the sclera becomes exposed.